Chapter 3 is government-sponsored healthcare programs. In this chapter, we're going to learn about the different government-sponsored programs, Medicare, Medicaid. We're going to talk about their cost-sharing responsibility for Medicare beneficiaries, and then we'll also learn about some other government-sponsored programs that we have, TRICARE. We have some for children. We have PACE. So we'll learn about some other. The primary will be Medicare and Medicaid. So we're going to start with Medicare. Medicare originally started in the 1930s. It was called the Old Age Benefit Plan. It's a national health insurance for older adults and other people who may qualify. It is ran by CMS, which is the Centers for Medicare and Medicaid Services. It did change in an amendment, which was the Social Security Act, and that is in Title 18 there, and that was in 1965, and it was actually implemented in 1966. It kind of changed around some of the beneficiaries and what it actually did as far as services that were provided. It stated in this new amendment in this act that the beneficiaries were individuals that were 65 years or older who were eligible for Social Security or who were eligible for railroad retirement benefits. It stated that persons with a permanent disability were eligible for Medicare, and then it also said that people with end stage, whether they were adult or children, were also eligible for Medicare benefits. So those were the people that were eligible. Now, in 2010, there were two laws that kind of affected Medicare, and that was the Affordable Care Act and the Patient Protection Act, and both of those were designed to improve the quality of the Medicare services and kind of look at new payment plans, better align those payments with the cost, and to strengthen Medicare. Before that, Medicare had gotten to a point where financially it was not doing what it was supposed to be doing, and the care for a lot of Medicare clients was not what it should have been. So when we talk about Medicare, there are four parts to Medicare. We have Part A, Part B, Part C, and then we have Part D. So with Part A, this is eligibility if you have worked and paid Medicare taxes for at least 10 years. So anybody who has worked and paid Medicare taxes for at least 10 years, this is provided. There's no premium to it. You do have to pay some cost sharing for it, but it is free to you as long as you have paid those Medicare taxes for at least 10 years. And it is basically hospitalization insurance. It is for inpatient, long-term care hospitals, skilled nursing, home health, and for hospice. And we're going to look at it just a little bit more in a minute. We're going to look at all of these. So we're going to kind of summarize, and then we're going to go and look at them a little bit more. Part B is a voluntary supplemental medical insurance. So it's optional. It covers your outpatient services. So it would cover like a doctor, medical services, medical supplies, things that are not covered by Part A. It does have an annual deductible, and it does have copay per service. Now, usually the standard premium for Part B is $164.90. If you make over $87,000 a year, it does go up slightly. Part C is a managed care option, and it kind of combines Part A and Part B, and it's optional as well. It's only available in some areas. It has HMOs, PPOs, it has case management, disease management, dental, eye exams, fitness. It has hearing care, transport. It advertises on the TV a lot. So sometimes you see this on TV where this is being advertised for these managed care options. It has special needs plans for people that are qualified for Medicare and Medicaid, for patients that have chronic care, for patients that are in institutions such as nursing homes. With these managed care, CMS rates these plans like a 1 to 5 star, and if you're consistently a 4-star or above, then these people get extra money for their services that they provide. The average premium on these is $19. Why wouldn't I take it? Because it's managed care and some people don't want to do that. So a lot of times you may lose the ability to pick and select the doctors that you want to use. Part D, this is our outpatient prescription drug coverage. This is for your drug plans. If you'll notice, A and B don't pay for drugs. C doesn't pay for drugs. So you will usually have to have a Part D on top of C or A and B. Your premium usually varies depending upon what plan you select, and sometimes it can be based upon your yearly income. They look at the past 2 years to see what it is that you can actually pay. So let's look at each one of those a little bit more. So Part A. Now, Part A has this table 3.1. It's on page 43 in our book. Remember that this is free as long as you paid for 10 years your taxes. So most everybody who's worked at least 10 years is eligible for Medicare Part A. Remember, you have to meet those requirements. You have to be 65 or older, eligible for Social Security, all of those requirements for Medicare. If you're 40 years old and you just decide you want to go get Medicare Part A, you can't do that. You still have to meet the Medicare requirements. There are cost sharing, and here are the cost sharing tables. So this table is a great tool that many times when you're testing that they're going to show you, and you're going to have to determine cost. So let's look at it just a minute. So it pays different prices based on the number or what day you're actually in the hospital. So if you'll notice here, you have a $1,600 deductible, and then you pay $400 per day for the first 60 days. For days 61 through 90, it's $800 per day. And then 91 through 150 or so on, it covers all of the cost. For a skilled nursing facility, you pay nothing for the first 20 days, and then after that you pay $200 per day for 21 through 100. Home health, you pay nothing for services, but your durable medical equipment, DME, is included in your Part B, and we'll look at that table. Hospice, there's no time limit, and there's a limited cost for the drugs and then for respite care. So depending on your site of service, there is some beneficiary responsibility that will have to be paid, even though there is no premium. So remember that the premium is how much you pay a month. So there's no premium, but there is cost sharing, which is your copays. Now remember, we learned about in our insurance chapter that a lot of times our copays are put into place to prevent people from just going to the hospital to use those services. When it was free, they were overusing. So if you put a cost to it, sometimes they don't use it as much. So on page 43, there is an example. Shanice is 65 years old. This is her fourth acute care inpatient admit for the year. She has satisfied her deductible during her first admission. The first admission was 28 days. The second admission was 25 days. And the third admission was 10 days. So let me stop right there and think. This is her fourth admission. She satisfied her deductible. So I know that she has met this $1,600. So now what I need to do is add up the number of days and see if she is in her 60-day period. So first of all, she had 28 days. Then she had 25 days. Then she had 10 days. And then she had 15 days. So the first three admissions totaled 63. Therefore, Shanice has exhausted her Medicaid days for this benefit period that do not require her copay amount per day. Her entire fourth admission is in the days 61 through 90. Shanice is responsible for cost sharing amount of $6,000. So how did we get that? So we have $800 per day. Is that right? Her entire fourth admission is days. They have 400 times 15. Let me get my calculator and do some math. 28 plus 25 plus 10 is 63. 15 times 800. Okay, so I think that is that should be 800 times 15 for the fourth admission, based on our beneficiary, because our beneficiary days is 800. This is a new edition of the book. We might have found an error. Let me grab my old edition. And see if in the old edition the amount was different. And the example didn't update. I think that should be, I think that the responsibility for the care there, that should be 800 times 15, which would make her cost sharing $12,000 based on days 61 through 90. So I think that's a typo in the book there on example 3.1. So if you have questions on that, send me a text, but or send me an email, because I think that is a typo in the book. Now, I want to give you another example. Let's say that the patient has to go in for the very first time. Let's say it's their very first time in the hospital. in this case, it was their fourth admission. But if it was a first admission, they would have to pay their deductible and their copay. So let's say that they were there 2 nights. First time that they were in the hospital, and it was 2 nights. So we would have to pay $1,600, and then 2 nights would be $400 per day. So we would have to do 1,600 plus 400 twice would be a $2,400. Now that would mean that we actually have met our deductible and we are now paying our copays. On this test, there will be some math that you're going to have to do. So make sure you know how to do the calculations, and there will be a calculator on the test. Okay, Part B. This table for Part B is over on page 44. So now remember that Part B is the supplemental insurance, where we are going to be paying for doctors, labs, x-rays, anything that isn't covered in Part A. And you can see that with this, we have a different deductible. So it does require a premium. So that's why it's voluntary. It does have cost sharing. And here's some of the services. So this has a different amount. So our medical services, we have a $226 annual deductible plus 20%. So on here, most everything is 20%. That's the way that we do most everything with our services, is 20%. Now you can see here for labs, we don't have any responsibility. Home health services, DME. Everybody knows what DME is. That would be medical equipment, canes, wheelchairs, a bedside commode, anything that is a piece of medical equipment. A cast would not be. A splint, however, would be. Our outpatient is going to be that annual deductible, same as up here. Then we have that 20%. Mental health, we don't have anything. And then this shows what benefits are covered. Now, I want to make sure that everybody knows how you determine 20%. So again, we're going to have a calculator. So if I have a calculator on my, let me see if I can pull up my calculator. Let's pull up a calculator. So let's say I have a charge for physical therapy of $125, and I multiply that times 20%. I would pay $25. That would be my charge. So let's do another one. Let's say I have a charge for, I don't know, an outpatient procedure of $275. I multiply that times 20%. My charge would be $55. Now, another way that you can do that, if it doesn't have the percent symbol whenever I'm doing my multiplication, let's go back. 125 times 0.20. Same thing. And what was the other one I did? 275 times 0.20. Remember that when I have percentages, all I'm doing is taking my percentage. If my percentage is 20%, here's my decimal. I'm moving my decimal 2 places to the left, and that's where that goes. So in most of these cases, everything is 20%. So I'm just going to multiply it like that. Now, there may be some cases where I have to do multiple items that I have to do. So let's say that I have a patient that this is their first time that they are coming in for a medical service. So let's say that they have a charge of, let me go back, backspace. Let's say that they have a charge of $550. And you may want to write that amount down, and let's do the math together. So they have a charge of $550. I don't know, let's say that they went to the doctor. They had I don't know, something taken off of their leg or something. $550 physician service charge, and it's their first time. So the first thing I have to do is they haven't met their deductible. So I have to take that $550, and what do I have to do? I have to take that $550, and the first thing I have to do is subtract my deductible, $226. So that leaves me with $324. Now, based on this, once I take that deductible out, I'm still responsible for 20% of that money. So now I'm responsible for $324. So I'm going to say 324 times 20% is $64.80. So when you take this test, you may want to have a piece of scratch paper handy because you may have to do a little bit of math. All right, now what is my total? I'm going to give you a minute. And that would be the total amount of cost sharing that that patient is responsible for. So it's a first-time physician charge of $550. In the end, that patient would be responsible for $290.80. So we took $550, we subtracted our $226 out, I put it to the side. That left me with $324. I have to pay 20% of that, which is $64.80, and then I had to go back and add that to my deductible. Now, one other statement I want you to look at on here. It says the facility copayment for a single service cannot be higher than the hospital Part A deductible. So that's saying per procedure, the service limit can be no more than the Part A deductible, which was $1,600. So you need to know that the most they can do for an outpatient is it can't be any higher than that. That's important to know. All right, let's look at page 45 and see if they got this one right. This is example 3.2. It's on page 45. So Mateo is seen in the hospital outpatient GI endoscopy lab for a colonoscopy with a biopsy. This is his first outpatient encounter for the year, so ding, ding, ding. he's going to have to pay that $226 annual deductible. He's already satisfied his Part B deductible because he's seen his physician several times and received physical therapy for his lower back. Since he's receiving care in the hospital, he will be responsible for cost sharing for both physician services and facility. The allowed charges for the physician is $285. He's responsible for 20% of that, which is $40.17. The allowed charges for the facility services is $1,422. And he's responsible for 20% or $284. His total is $241.02. So let's check the math and make sure that that is right. All right, so let's look at our table. So he's outpatient encounter. He's already met his deductible with his doctor. So for outpatient services, he's just paying 20% for the services. And then he has paid to the physician. There's also a copay for the hospital. So facility service, so it's going to be 20% for both. That's what it says right there. So 200.85 200.85 times 20%. It's $40.17. And then he's got 1004.22. We'll add those two together. Close enough. All right. So that's that one. That's Part B. Now, a lot of times you will hear people in healthcare say, if you're able, don't get rid of your Part A. Always try to keep, excuse me, going through puberty here. Always try to keep your Part A if possible, and then buy Part B to supplement. If you're not able to do that, then you want to move to Part C. Once you go to Part C, you can never go back. So I think that's why people tell you that you can't go back to your A if you ever go to Part C. So Part C is our managed care option. This one is the one that has more services that are provided. It covers dental, vision, glasses, everything that's in A or B combined. It is managed care like we talked about in Chapter 2. It covers everything, and there are some that do have some prescription, but you may still need to buy that Part D. It does require a premium, and it does have cost sharing that goes along with it. Now, depending on what plan you buy, it will have different requirements. It's not like Part A and B. Part A and B is ran by CMS, so everything is going to be exactly the same as what we looked at in those two tables. Part C can be ran by independent insurance companies, so those are going to be different dependent upon what insurance company that you go through. You'll actually see where there's some Medicare Advantage that may be ran by the same insurance company that runs some of our employee-based insurance companies, and those may not be ran through CMS. So they don't necessarily have to follow those same deductibles. They may be different. But do you know that Part C is managed care? And one of the things about it is that it does have the Part C and it may have a lower premium, but keep in mind it is managed care, so you will have to go through your primary care for referrals. You will have to have a primary care, and you have to make sure that you're following in-service, in-network providers. Part D, this is our prescription drug plan. This is also got a premium, deductible, co-payments. It is also ran through private insurance companies. There is something with Part D that is called a coverage gap or a donut hole, which is an expanded cost sharing. At some point during the year, your medicines will go way up in cost and then they will start coming back down. It's just the way it works. Not sure why they've got it set up that way, but that is something to keep in mind when you think about Part D, is that it has that coverage gap, which is that expanded cost sharing known as the donut hole. You hear people talk about that all the time, depending on the cost of their meds and the amount of meds that they use. Now, there are also Medicare supplemental insurances. These are supplements. Sometimes they're called Medigaps. These are known as cost-sharing supplements that they help to pay for some of those costs that we see in Table 3.1 and 3.2 that we were looking at. This is a private insurance plan. AARP offers a Medigap. Sometimes you'll see that advertised on TV as well. This is just, Aetna has one, I think, too, that if you buy it, you pay for it, and it will help you with those co-pays that you have to pay. You know, $1,600 is a lot of money if you're put into the hospital, as well as those per day costs. So this is a supplement, and it does vary again as far as how much it does cost. And that's just a Medicare supplement insurance. Before we go to Medicaid, let me say that Medicare is federally ran. So no matter what state you go to, Medicare is going to be the same. It is Medicare here. It is Medicare in Florida. It is Medicare in Alabama. Medicare is Medicare no matter where you go. And it's ran by CMS. All federally ran. All the same services, same deductibles, same cost sharing. Next, we're going to talk about Medicaid. Now, this used to be called the Medical Assistance Program. It came about in that same Social Security Act in 1965, and it is a joint program between the federal government and the state government. So this is a state program. It is for individuals and families with low income and limited financial resources. It is a program that is unique to each state. There are federal funds that are given, but those funds are based on the average income per person. It must cover infants born to Medicaid eligible pregnant women, and it must offer a managed care option. So those are requirements that it has to have, but you need to know that it is a joint program between federal government and the state, and that the states determine the eligibility. They determine the type, the amount, the duration, the scope. They have to offer the managed care. They have to cover infants that are born to Medicaid eligible pregnant women. And those funds are based on the income, and that it's different for each state. Medicaid in Georgia is different from Medicaid in Florida, from Alabama, from any other state around. So here's some things, and on page 47 in your book, there are some mandatory things and then also some optional things that you'll see. But to receive funds, they have to provide care for poverty-related infants, children, pregnant women, and deemed newborns. Low-income families, families receiving transitional medical assistance, children with Title 4E adoption assistance, foster care, guardianship care, children aging out of foster care, elderly and disabled individuals receiving Social Security incomes, and aged, blind, disabled individuals who live in 209B states, certain working individuals with disabilities, certain low-income enrollees such as specified low-income Medicare beneficiaries, which is an SLMB. Services can be expanded based on state laws and regulation. States will determine the cost sharing for the individual, and they can expand their eligibility. The ACA updated some of it, and they said if you were under 65, not pregnant, not disabled, but your income was 133% of the federal poverty level, that you were required to receive Medicaid. States can offer the managed care option, and then there are 4 types for Medicaid, and they're listed on page 48. There is just a managed care, a primary case management, a prepaid inpatient, and a prepaid ambulatory health care. And there has been a growth in the Medicaid MCOs in the past few years. They've just seen more growth with that. So that's Medicaid. Remember, it is ran by the state. So I want us to look on page 48 in our textbook, and there's the check your understanding, and I want us to answer some of those. And I know these answers are, I think these answers are in your book, but I want us to look at these together a minute without doing the check your understanding. So, without cheating, let's look at these a second. So for part A, B, C, and D, it's asking us to know which benefit is which. And this is very important that you know for your Medicare. So part A, that's our inpatient hospital services. Remember that is, if I've worked 10 years, paid Medicare taxes. Now, Medicare drug benefit, remember that is part D. My physician services, that is part B. And my Medicare Advantage is part C. Then let's look at these questions a minute. Number 2, Arnav is a Medicare beneficiary who is covered under Part A and Part B. His first acute care inpatient admission for the benefit period was 10 days long. This was his first health care encounter for the benefit year. The allowed charges were $7,845. What is his cost sharing? All right, so let's get our calculator back up. Let's go back to this. Okay, so his first encounter, he had 7845.50. 78, 45, 50. His first acute care inpatient was 10 days off. This was his first health care. So y'all take a minute. Let's see. So we know that we're going to take our 1,600 so we know he's got to pay the 1,600 and his first acute care inpatient. This was the allowable charge for admission. What is his cost share in 10 days? So I have to pay his deductible, and then he'll have to pay for his 10 days. So what did you get? So 1,600 for his deductible. Okay. And then 10 days at 400 is 4,000. So 5,600. All right, and again, they haven't updated their answer in the back. So the answer to that is 5,600. So number 3, what benefits will Medicare gain by Part C? So remember with Part C, that's the Medicare Advantage. That's going to give you the A and B, plus you get the dental, the vision, all of those extra items that you get with, let's minimize that. Let's look at Part C. So with that, you get the dental, vision, health, wellness, hearing aids. So those are the extra. Number 4 there, that Part D coverage gap. Remember, that's where it gets higher when you reach a certain amount of out of pocket, and then it's going to drop down. And then why is Medicaid coverage not identical in those states? It's because that coverage for Medicaid is, each state is unique. It's a partnership between the federal government and the state. It is not something that is federally operated. It is something that each state can choose to run any way they want, with a few requirements from the federal government. So keep that in mind. Sometimes Medicaid and Medicare can be a little confusing. All right, so let's move on to some of our other. Oh, went too far. So the next one we have is PACE. PACE is Programs for All-Inclusive Care of the Elderly. It came from the Balanced Budget Act of 1997. It is not in all states. It is kind of an agreement between the state and CMS. PACE, basically, in a nutshell, is managed care for frail elderly population. So this is a way to keep the population in their own homes, in their own communities. They have facilities with providers that are set up in these areas that they take care of these elderly patients and keep them out of nursing homes if they are able to live in the community without having to go into a nursing home. I'm not sure that we have any in South Georgia. There may be some up around the Atlanta area. Page 49 and 50 list the types of service that are provided by PACE. And then it does list also on page 50 the type of providers that must be on that team of caregivers for PACE. So again, managed care for frail elderly. Know what that provider is and know what the service is. Next, we have CHIP. This is the Children's Health Insurance Program. It was created in 1997. It is a state-federal partnership again. It aims to provide insurance to children whose family income is too high for Medicaid, but they're unable to pay for private health insurance. An example would be like Peach Care for this. Oops, let me change my slide. This also came from the Social Security Act. There are some requirements. You do have to be less than 19, uninsured, a citizen or meet immigration requirements, a resident of the state, and then you have to meet the certain income requirements for CHIP. Your state can make a separate program or they can add it to Medicaid, but CMS does have to approve that plan. It does have to require, it does require inpatient, outpatient, doctor, labs, and x-rays. There can be cost sharing or there may be none. In this plan, there can be no cost sharing for American Indians or Alaskan Native children. So again, Children's Health Insurance Program, and it also is a state and federal partnership. So know what CHIP is. Next, we have TRICARE. TRICARE is ran by the Department of Defense. It is for active duty members of the military and family members. Also for activated Guard Reserve members and retirees as well. It is comprehensive coverage, outpatient hospitalization, preventive care, maternity, immunizations, mental health. So it kind of provides a full spectrum of services. These are the plans. If you'll notice there in the green, it kind of gives you a key for those abbreviations that are used. So the first one there, the Prime and the Prime Remote, these are managed care options. There's no deductible, no copay. Most people enroll during the open enrollment. It's the most economical. you have to live and work within 50 miles or less than an hour from a military treatment facility. You have a primary care manager. The prime remote is if you live in a remote area, and that just allows you to see an out of network if you need to be treated. The Prime Select or the TRICARE Select, this is a higher cost sharing and it costs more. The TRICARE Young Adult is if you're unmarried and not eligible for work insurance. It's a premium based with cost sharing. We have the Reserve and Retired, that's premium based. And then we have TRICARE for Life, which is a secondary coverage, and that just kind of it's for those people that have Medicare A and B, and it minimizes the cost sharing. So it's like a supplemental, kind of like we talked about the Medicare Medigap. Next, we have the VA. All veterans are encouraged to apply, but you must apply for this. In order to be eligible, veterans who served in active and military service and were separated under any condition other than dishonorable. And it's important that you know who is eligible. Any condition other than dishonorable. So if you were dishonorably discharged, then you would no longer be eligible. There are co-payments for non-service conditions. Once you enroll, they place you into a priority group, and those groups can be seen on page 54. And that's figure 3.2, not 3.3, like it says there on the slide. And that's kind of a sample. And so once you get placed in that group, then your benefits are kind of dependent on that, as well as your cost sharing. 1,200 care sites, 9+ million veterans are served, little or no cost. You can get a private insurance that can supplement those co-payments. When you first enroll, you do a financial assessment, which kind of helps to determine whether or not you can pay and how much you are able to pay. Next, we have CHAMP-V. This is our civilian health and medical program. CHAMP-V is for the spouse or widow and children of a veteran who meets one of these requirements: dependent survivor of permanently and totally disabled veteran, survivor of a veteran who died of a service-related condition, or a survivor of military personnel who died in the line of duty. This program covers most healthcare services and supplies that are medically and psychologically necessary. So this is CHAMP-VA, CHAMPA. If family members qualify for TRICARE, then they cannot enroll in CHAMPA. They are treated at VA healthcare facilities. They do have an outpatient deductible, and there is some cost sharing. So for these other things that we're talking, you're going to see that it's not as detailed as Medicare, but you do need to know what each one of these programs are, and you kind of need to know what the abbreviations stand for. Next, we have the IHS, that's the Indian Health Service. This is ran by the Department of Health and Human Services, and it came about in the 1920s. It actually upholds a government obligation from the 1700s that we were going to government to government promote healthy American Indians and Alaska Native people. So this covers preventative care, immunizations, primary medical services, community health services, and rehab services. What does it provide? It helps with inpatient, outpatient care. It assists in developing their own health programs, facilitates and assists in their own health plan coordination, and it promotes using health resources at the federal, state, and local level. Again, it assists in developing their own health programs, facilitates and assists in developing of own health plan coordination, promotes using health resources, and it does help them with their inpatient and outpatient care. Now, at one time, and I'm not sure if this is still true, if you were on a reservation and you were non-American Indian, you could not receive services unless it was a life-threatening emergency. So I'm not sure if that's still true or not, but at one time, those services were only provided to American Indians. Next, we have workers' comp. Workers' comp is provided to employees for work-related injuries or illness, and it covers their health care cost and their lost income. It is legislated by the individual states, and you can see there that it covers burial, death, income, and medical. Now, in these states that mandate it, what happens is the employer pays premium into the state workers' comp fund. So they don't have to go out and find their own workers' comp insurance. They pay it to the state, and that kind of keeps their premium low. In a state that does not mandate workers' comp, then that company has to go and purchase from a private insurance company. Now, if you're a federal employee, then they have the Federal Employees Compensation Act. This is established in 1916, and this is for federal employees. So this is a federal workers' comp if you are a federal employee. And that sometimes is abbreviated FECA, and that would be the Federal Workers' Comp. So if you work for the post office, let's say, then you would fall under the federal workers' comp versus the state workers' comp. All right, before we get to that, let's look at the page 55. Let's look at the match your TRICARE. Let's look at those questions at the bottom of that page there. So it says to match your TRICARES. So we have ADFM, age 21 to 25. So just based on the age, let's go back and let's look at those codes. An active duty family member, age 21 to 25. By the age, that's going to be our young adult. A traditional insurance plan for ADFM's the non-managed care. Let's see, non-managed care. Which one was our non-managed care? That's going to be... Select. The managed care is going to be our prime. And then the for life is going to be our secondary payer. So TRICARE for life is D, the secondary payer. TRICARE Prime is going to be our managed care. TRICARE Select is our traditional insurance. And then TRICARE Young Adult is our A. That's for our number 2 on the top of the next page. Which population is targeted by PACE? And that's the frail elderly. Remember, that is the frail elderly population. And why was this population selected? And that was because we want to try to keep them living in their homes. Number 3 there, how are veterans placed into those different levels? And that's by their service. Let's see, I'm not sure if that slide had anything about the services or not. Coverage is based on the groups, and that was our figure 3.2 on page 53. And it's based on their service. Number 4 says to tell us, how does CHIPS vary by state to state? So remember that CHIPS is like Medicaid. CHIP varies from state to state. So let's look at CHIPS. CHIPS was in our book. It's on page 50. So it could be the coverage. It has different types of coverage, and there's some different coverages. Could be what is the deductible. How many did it want us to tell us? Could be the deductible, or it could be, what were some other things? The screenings. It could be, does it provide dental or not? What dental services does it provide? Could be, does it provide cost sharing? Does it combine with Medicaid, or does it have its own separate program? Oh, how many children? It says here almost 10 million children are currently enrolled in CHIPS. So that's a little bit about CHIPS. All right, now let's go to those last slides there in our... Okay, so Malachi, this is our little patient at the end of the chapter. Page 56. 68 years old, who's enrolled in Medicare. Malachi is enrolled in traditional Part A and has purchased Part B and D. Malachi's Part B premium is $170 per month. His Part D premium is $30 per month. Malachi's friend Zach is enrolled in Medicare Advantage plan through Best Insurance Company. Zach told Malachi that he only pays $50 a month for his Medicare premium. Malachi decides to investigate why he's paying so much more in premium for traditional Medicare and wants to understand the impact of switching Advantage plans prior to his meeting. Okay, so A and B, that would be our traditional Medicare. He has Part A, that's our hospital. He has Part B, which is his pays for his doctors. Part D pays for his medicines. Malachi took the managed care option and pays $50 a month. So they're going to research the cost on the Medicare.gov website. There are several qualifiers for how much it actually costs a beneficiary. So they're going to list out. So the biggest concern is to be able to still see his own doctor and how much he'll pay for each visit. During his meeting with the best insurance company, he finds out he has to pay more to see out-of-network providers. Office visits and physical therapy will have a copay of $15 for the upcoming year, and there is one annual deductible of $150 for all types. Dr. Lewis is not included, so instead of a $10 copay, he'll have to pay a 30% coinsurance amount to see Dr. Lewis. Currently, he only pays 20%. To help him decide, he uses an estimate of his medical expenses from last year to Medicare Advantage rates offered by Best Insurance. So, outpatient visits with Dr. Lewis, this is what he paid last year. So his traditional, he paid $226 deductible and $120 for his coinsurance. For physical therapy, he went 6 times, paid $180, nothing for that, and that was his total. If he goes to the Medicare Advantage plan, $150 plus $180, so he'd pay $600, cost him $90 for physical therapy, and nothing all. Okay. And all of this is on page 56 and 57. Overall, even with Dr. Lewis being out of network, Malachi would most likely pay less under Medicare Advantage. But what if he has to see the doctor more often? Currently, he hasn't